For patients with the standard kind of sensitizing mutations, exon 19 and L858R, I think the FLORA trial has kind of led me to use osimertinib as the first-line therapy for all of those patients. Initially, I think when the FLORA trial first came out, there was some discussion about whether we should be sequencing these agents and whether maybe there would be some benefit to first giving them erlotinib or gefitinib, and then if they develop T790M, leaving osimertinib as a kind of an option for second-line therapy. I think that the challenge with that kind of paradigm is that only about 50 to 60% of these patients will develop T790M, and then we'll get to the second half of that sequence. Whereas if we give osimertinib first line, we know that they're going to benefit hopefully for as long as 19 months or longer. And so to me, I think that sequencing question, once I saw the FLORA data, I really thought osimertinib, I've always been taught, give your best drug first, and that seemed to be the approach. I do still, consider the particularly second generation EGFR inhibitors like afatinib for patients with the uncommon but still sensitizing EGFR mutations. Afatinib is the only FDA-approved therapy for those mutations right now. These are things like the G719 mutations, S768I, and others. However, we have started to see now emerging data with osimertinib for those mutations as well, and so I think that certainly that data looks promising, and I anticipate that we may move to using osimertinib for those patients as well.